All right, welcome back. This is part 2 of my COVID-19 update. For those of you who didn't catch part 1, I definitely recommend going and catching those 5 topics. My name is Salim Rezai. I'm a community ER physician in San Antonio, Texas. I work for a group called Greater San Antonio Emergency Physicians. I stated this in part 1, I think is probably the best group in the world. I've been with them for 4 years, and I'm always just blown away how they always do everything right and always trying to take the best care of patients. I'm the director of clinical education for them, and so this is a talk that I kind of put together not only for my group, but I've also given at multiple conferences, and the feedback was, can you make this available as a video or with some resources that we can access when we need it? The final thing I'm going to tell you is that I have no financial conflicts of interest for anything we're going to talk about in this talk. And the last thing is that this is being recorded on October 13th, 2020. And so the evidence that I'm going to go over is through October 13th. So anything that comes out after that, obviously we may need to update the video, and I may have other subsequent videos that come up from this. Now, in part 1, we went over when to change practice in the midst of a pandemic with all this research that's coming out and retractions. We talked about when to, or not when, but how to reuse N95 masks safely. We talked about corticosteroids, we talked about remdesivir, and we talked about convalescent plasma. I think right now, those are the things that have the most evidence. Not all of it is good. Some of it is and some of it isn't. But regardless, I go through all that and give you all the links for it. Part 2, we're going to be looking at some more controversial topics, and there may be some things here that people disagree with, and that's okay. I think it's good to have disagreement, but I think doing it in a collegial way where we have discussion, because at the end of the day, all any of us are trying to do, myself included, is take the best care of patients that we can. And so some of these things have very limited evidence for them. Some of them are anecdote, and some of them are case series. And so not really superb levels of evidence yet. We hopefully will get there, but this is kind of where I think we're at with each of these topics. So we're going to start with anticoagulation. We'll talk about awake proning, invasive mechanical ventilation, ECMO, and then finally we'll end with what I think is the biggest debacle in COVID-19 management, which is hydroxychloroquine. So let's start with anticoagulation. And I think this is a really controversial topic right off the bat. And the reason is that the evidence for this isn't super robust. And you'll see people talking about, oh, everybody should be on a prophylactic dose. And some people will talk about, no, they need to be on a full dose. And then some people saying, well, full dose is probably too crazy. Prophylactic dose isn't enough. So let's put them on something in middle of the road. And so I think we should kind of go through what is available and what is the best evidence we have and how we extrapolate that to our patient care. So the first thing I want to say here is that when we talk about thrombosis and viral illness, people talk about like, it's no surprise, viral illnesses cause thrombosis. And this is actually true. There are studies comparing COVID-19 to other viral illnesses, in this case, H1N1. And it is true, they both cause thrombosis. But what's fascinating when you look at the pathophysiology and you look at pathology studies, it looks like alveolar capillary microthrombi are 9 times more prevalent in COVID-19 than they are in H1N1. So whatever's going on, it looks like we're getting way more thrombosis than we are with other viral illnesses. So although both statements are correct, it may be that COVID-19 is causing way more thrombosis than H1N1 and other viral illnesses. Now, early in the pandemic, this was something I advocated for, was using D-dimer levels. I think we need to remember that it is an acute phase reactant. So if D-dimer is elevated, is it because of the viral illness or is it because there's actually clot there? It is associated with a higher mortality, but unfortunately, most trials are small and retrospective, and it's really unclear how to use this. I think early on, we were using D-dimer cutoffs to determine how we wanted to anticoagulate patients. But really, D-dimer is just a marker of illness of severity and not anticoagulant dosing. So if you have an elevated D-dimer, other things I want you to know are you don't have to CT all patients. The guidelines support us on this. Don't forget about arterial thrombosis. So this would be things like MI, CVA, peripheral arterial thrombosis. And then elevated D-dimers, like 3 to 4 times the upper limit of normal, should equal admission in these patients because this really needs to be trended out because it is a marker of severity. Now, the American Society of Hematology, their recommendations officially are all hospitalized patients should receive thromboprophylaxis. That can be either low molecular weight heparin or fondaparinux. They recommend this greater than unfractionated heparin to reduce the number of times staff has to go in the room and be around the patient. Now, typically with low molecular weight heparin, this is dosed at 40 milligrams sub-Q once a day. I highly recommend weight-based dosing here, which is going to be 0.5 milligrams per kilogram sub-Q once a day for the prophylactic dosing. Now, there is one observational trial out of New York when they were in the middle of their surge. It was just over 2,600 patients, and they looked at full dose versus prophylactic dose. What we don't know is why some patients got full dose and why some patients got prophylactic dose, but they were able to look at some interesting things. So the first thing is, if we look at in-hospital mortality, there was really no difference between the two groups. So whether you got full dose or you got prophylactic dose, mortality was still pretty high at that 22 to 23% range. Bleeding, no surprise. Patients who got full dose, there was a little bit more bleeding, 3% versus 2%. But what was fascinating was in patients requiring invasive mechanical ventilation, what we called the inflammatory phase of disease in part 1 of our videos, there was a significant decrease in mortality, 29.1% versus 62.7%. So what am I doing with anticoagulation? I think if a patient's getting admitted with COVID-19, they should get VTE prophylaxis. Again, this is weight-based for low molecular weight heparin. This is going to be 0.5 milligrams per kilogram sub-Q once a day. If they have acute kidney injury or CKD, then you can go with heparin, 5,000 units TID. If there's contraindications to bleeding, like they're actively bleeding or they're high risk for bleeding or their platelet count is low, less than 25,000, it doesn't mean we can't prophylax. It just means we're going to have to use sequential compression devices or some other form of mechanical thromboprophylaxis. And then for my invasive mechanical ventilation patients that are coming to the ICU, these patients are getting full dose anticoagulation. Again, this is completely going to be system-based. There may be some people who disagree with this, and that's okay. I'm just going based on the best available evidence I can find. Now, I'd be remiss if I don't talk about thrombolysis, because there are some case series and case reports of people getting thrombolysis. So you have a patient with COVID-19, they're in this hyperinflammatory phase, you have them on prophylactic medication, or you have them on therapeutic anticoagulation. And so then the question becomes is, does thrombolysis help? And the answer is it's not recommended. The studies that we have so far show that you'll have a transient improvement in your PF ratio, which ultimately goes away after the medication wears off. The only indication for thrombolysis with COVID-19 is if they're having an MI, which these patients should still go to the cath lab, they're having a massive PE, or they're having a stroke. So other causes that would benefit from thrombolysis, but not in just COVID-19 itself. Intermediate dosing, I touched on this a little bit. This is a very controversial topic. I'm going to say at this time, there is zero evidence to support this practice, but there are going to be some systems that vote that prophylaxis alone is not enough. And so maybe we'll just go with an intermediate dose. And I can't argue with that. I can't say it does or doesn't work. What I can say is there's just no evidence to support it at this time. Here are two blog posts that I have on Rebel EM. The first one is a lot of research and evidence looking at thrombosis and anticoagulation. And the second one is a comparison of COVID-19 to H1N1. I actually think that was a really fascinating pathology study that was done, and it shows all the similarities between the two viruses and the ways that they're different. So proning. So proning is an interesting topic. So I think there's evidence obviously out there for patients who are intubated, who have ARDS, and turning them over onto their stomachs to help recruit atelectatic alveoli. But what is the evidence for doing this while patients are awake with COVID-19? And so what we can see is that when you turn a patient over, really you're doing two things. The first is you can see the posterior aspect of the lungs. There's alveoli that are kind of compressed. And when you turn them over, you can see on the green circle, those start to get recruited. The second thing is that we know that the virus seems to like the posterior aspects of the lungs better than it likes the anterior aspects. Now, it doesn't mean it doesn't infect the anterior aspects, but early on in disease, it really seems to go for these posterior segments of the lung. And so the second thing proning does is it shifts blood flow away from the atelectatic alveoli with infected COVID-19 as well as shifting that blood flow to patients who have healthier anterior lung segments. So there's lots of people talking about this from anecdote. We all know that the plural of anecdote is not data. There's physiologic reasons that I just went over, and there's clearly evidence in intubated patients. The question is there robust data in COVID-19? And the answer is no, there's not. There's an absence of it. Now, the two best trials on this, the first one is an observational trial of 50 patients, and they looked at awake proning, and they just basically asked a simple question. Does awake proning improve oxygen saturation in patients with COVID-19? And the patients that were recruited had an SpO2 of less than 90%, and they did not improve significantly with supplemental oxygen. And what they did is they recorded oxygen saturation at presentation, on nasal cannula or non-rebreather, and then ultimately after 5 minutes of proning them. And they looked for a change in oxygen saturation, and here's what they found. At presentation, the average was pretty low, 80%. I think most of us would agree. Putting them on nasal cannula and non-rebreather, it improved it a little bit, but not significant enough. And then proning them, it brought it all the way up to 94%. Now, the thing to know here is that 36% of these patients, of these 50 enrolled patients, ended up being intubated in the first 3 days of hospitalization. So this brings up a few points that I want to mention about this study. So the first thing is this was early in the pandemic. This study was done in April. And at that time, we were still intubating a lot of these patients. And I think we've learned that we don't necessarily have to intubate these patients, both for our safety and for fear of these patients crumping. So I think that's the first thing. The second thing is that we know that intubating these patients is a poor prognostic factor. And that could just be severity of disease, or it could be from the ventilator itself. The second thing is, early in the pandemic, there was a lot of fear of using high-flow nasal cannula and non-invasive ventilation. In this study, they actually didn't use these two modalities, and I think this is a very, very important intermediary step because this does give us some PEEP, and this is really important, and it increases the flow of oxygen. So I think as we've gotten more comfortable with these devices, more and more people are starting to use them, and less are being intubated. The final thing I want to tell you is that pushing these patients to a point of becoming oxygen dependent is a very risky thing. And these patients cannot just go to the floor. These patients probably still need to go to the ICU or to a step-down unit where there is better eyes on them, or nursing to patient ratios. And the reason is that if we push these patients far enough, as you'll see in the next study, they can desaturate quickly if they become disconnected or if they flip back over onto their backs. And when they get disconnected and they become quickly hypoxemic, that's when your bad codes and all your bad stuff happens. So I'm not saying we shouldn't do this. I'm just saying we should have a healthy amount of being very proactive in maintaining these patients' oxygen saturations. And listen, I'm going to tell you, keeping a patient off a ventilator for 1 or 2 days more is a great thing. That's a win in my opinion, even if they end up getting intubated 3 days later. The second study on awake proning is only about 24 patients, and they basically looked at patients in prone positioning altogether, prone positioning and tolerating it for more than 3 hours, and then flipping them back onto their backs after they were proned. And here's what they found. They were looking for an oxygen saturation increase of greater than 20% on ABGs. This was only successful in 25% of prone positioning patients. It went up to 40% the longer they were able to tolerate, so greater than 3 hours. And when they flipped back, many of them actually lost that benefit. So there's 3 messages here I want you to remember from this study, although it's rather small. The first is not everyone is going to respond to proning. So this is important to realize, because if they're not responding, then they may require intubation. The second thing is that this is really uncomfortable, and the longer that they can tolerate this, the better chance of success. And ultimately, when they flip back over, the benefit can go away in some patients, and again, may be an indication for need for intubation. And so these patients need to be followed very, very closely. So here's the take-home messages on awake proning. It can buy you time from invasive mechanical ventilation. And I think that's a really good thing, because when we look at some of the early studies, as we'll talk about in just a second, mortality rates were up around the 70 to 80% mark once you were intubated, which is basically like a death sentence. The duration of proning is important. And the one thing I want to mention here is that this isn't just turning people onto their stomachs. People can turn onto their sides. They can sit up. They can rotate side to side. They don't actually have to be on their stomachs. The benefit comes from moving them around. And then finally, if you're going to be doing this, you need to have a protocol where there are frequent assessments, because if we push these people far enough, they will become oxygen and prone tolerant and will require these things and can quickly desaturate. This is a study on awake proning. I think it was the first trial that we went over, and this is the QR code to that. And for, again, all you nerds and statisticians out there, enjoy the kind of deeper dive. But ultimately, this is something I am doing in my practice, but this isn't something that you do and just throw people on the floor. All right, let's move on to invasive mechanical ventilation. And the first thing I want to tell you here is that we don't really know what mode is the best mode. There's a lot of people that talk about APRV or assist control with volume or pressure regulated volume control. I've heard arguments for all of them. And so far, there's no head-to-head saying this is better than that. So what I'm going to do is kind of start with a little historical perspective, and then I'm going to kind of get into what I'm doing, at least early on, for these patients. So early in the pandemic, as I've stated before, we were intubating everybody. I mean, they were just getting intubated left and right, and there was this real fear of running out of ventilators. And what we found from early studies is that mortality rates were anywhere from 50 to 90%, with an average being closer to 70 to 80%. So it literally was almost like a death sentence. Now, the question becomes, was it because they were just that sick, or was it the ventilator itself that was causing the mortality rates to be so high? Now, I think the reason we were intubating early in the pandemic is, one, we were fearful of aerosolization. We didn't want to get sick. We didn't want our staff to get sick, and we didn't want to take this home to our families. And then the second thing is we use experience to make decisions. And experience tells us patients who are this hypoxemic are going to tire out. And it actually turns out that's not the case with these patients. They tolerate this rather well for the most part. And so once we learned both those things, plus our intermediary steps of high flow nasal cannula and non-invasive ventilation, I think we kind of stopped intubating these patients a lot earlier. The next thing that kind of came up was this H-type versus L-type ARDS in these patients with COVID-19. And listen, I'm not going to get into the middle of a debate, but basically an H-type is high compliance disease with low recruitability. L-type is low compliance disease with high recruitability. And I got to tell you, my opinion on this is that they're not two different types of ARDS. This is progression of disease. Early in disease, we have a high compliance disease, and as the disease progresses, once patients get intubated, as more damage starts happening to those alveoli, we start shifting over to a low compliance disease. So I don't really think that there are two types. I think this is just the natural progression of the illness. But what is important is that early in illness, if we believe that most patients are going to be high compliance, then we need to be careful what strategies we're using, because the strategies we use for typical ARDS, which is low compliance, is this increasing PEEP ladder and prone positioning to help increase recruitability of atelectatic alveoli in these baby lungs. But that's actually not what's happening early in disease, and this could be potentially very detrimental and harmful and damaging to the lungs. And here's an example of that. So here's our hypothetical alveolus and the alveolar capillary. Now imagine for a second that this alveolar capillary is hypoxemic. So we're going to get some vasoconstriction. We already said there's more thrombosis. So now we've got this constricted vessel with some thrombosis potentially. And then we do typical ARDS, which is increasing PEEP and prone positioning, and we hyperexpand this alveolus. And what we're doing is we're now putting pressure on this already constricted and clotted off alveolus, and not alveolus, but alveolar capillary, and now we're creating increased right to left shunt. And this is actually more harmful to our patients, and they become much harder to ventilate and oxygenate. So we have to be really, really careful early in disease. So let me start with a couple of messages here, and then I'll come back to what I'm actually doing. So I think we need to not downplay high flow nasal cannula or non-invasive ventilation. They both buy us time. They help with patient care, and they reduce the number of patients that are going to require mechanical ventilation. Early in disease, this is high compliance. So this does not equal high PEEPs and prone positioning, because they're low recruitability, and high PEEP is going to hyperexpand those alveoli and put pressure on those alveolar capillaries. What we need to focus on is an oxygen first and a pressure last strategy, which I'll talk about in just a second. So for me, when I'm talking about invasive mechanical ventilation, I'm going to go with the mode that I feel the most comfortable with, and that is volume assist control. And this requires me to really set 5 things: tidal volume, respiratory rate, FiO2, and PEEP. I have those combined here because of the ARDSNet ladder, and then plateau pressure. For my tidal volume, I'm going to go 6 to 8 cc's per kilogram. The important thing here is this is ideal body weight, not actual body weight. Respiratory rate is going to be 16 to 18. Now, I said something earlier, which was oxygen first, pressure last, and that is that I'm going to start all these patients at 100% FiO2, and I'm going to set their PEEP at 5 to 8. Now, I can titrate PEEP up, but I will not go higher than 14 or 15. Most cases, I'm stopping at 12. In my overweight patients or patients who have kind of a larger chest wall, you might get up to 14 or 15, but overall, I'm not decreasing my FiO2. I'm actually going up on my PEEP first. So oxygen first, pressure last strategy. And then the final thing is that I'm using a plateau pressure. What is a plateau pressure? Well, you can ask your respiratory therapist or your intensivist, but essentially it's where you get the patient to do an inspiratory hold on the mechanical ventilator. This gives you the approximate pressure in the alveolus. So this is alveolar pressure. And what you want to target is a pressure of less than 30, because we know that once you start getting above that, this can be very, very harmful to the lungs. Now, if you are getting to pressures that are higher than this is where you may need to start thinking about paralyzing your patients, proning your patients, and maybe even thinking about some more advanced modes like APRV and asking for help from your intensivists. This is an example of a flow diagram where you basically have the patient, they take an inspiratory breath, there's an inspiratory hold, you get this slight drop off, and what you're left with is this plateau pressure. So the peak inspiratory pressure tells you the pressure that's in the airways, the plateau pressure tells you the pressure that's in your alveolus. So for invasive mechanical ventilation, oxygen first, pressure last. We want to try and delay intubation greater than the cost of intubation, even if this is 1, 2, or 3 days. High compliance disease early on. We want to try and keep our PEEPs down, shoot for higher FiO2s, and we're going to just have to tolerate lower oxygen saturations like 88 to 94%. Now, I have 2 blog posts on Rebel EM on this. This is invasive mechanical ventilation on the left, and it's airway management on the right. One is basically how to intubate these patients in a guideline, evidence-based, safe way. And then the second one is basically my thoughts on invasive mechanical ventilation. Let's move on to ECMO, our 4th topic. I'm not going to spend too much time on this. I'm going to assume for most of us, we're not actually doing the ECMO ourselves. I myself am not doing ECMO, but happen to work at a shop where ECMO is available. I've had multiple conversations with my intensivists who are doing this, and I actually have rounded up in the ICU where we're doing ECMO, and I've learned a ton. And actually, lucky enough, the intensivists were kind enough to let me cannulate a couple of patients while they were holding my hand. So I feel like I have some experience with this. By no means am I an expert, and by no means am I actually doing ECMO on my own. But I think I bring a unique perspective here. And after talking with my intensivist, I think this is a fascinating thing to talk about, because I think ECMO won't qualify for all of our patients, but there are going to be some patients where it's going to be really useful. So let's talk about ECMO in general, not with COVID, but typically the way ECMO gets used is as a salvage strategy. So we have our patients maxed out on the vent, we have them proned, we have them paralyzed, we have them on multiple pressors, nothing is working, and so we put them on ECMO. And the problem in COVID is that ECMO doesn't actually treat anything. It just bypasses the lungs. So once the damage is done, what you end up with is patients that end up on ECMO for 20 days or in the ICU for over a month. And this was something we noticed at our shop. There is a retrospective study that actually looked at this of 83 patients. And what they found is that when you use it in this manner, these patients tend not to wean, and then you have all these patients on ECMO whose lungs are completely trashed, and you probably initiated ECMO too late. Now, at my shop and the discussions with my intensivist is, well, what if there's a patient population where we initiate ECMO a little bit early? You know, a patient that just got intubated, or maybe patients that were requiring a lot of oxygen support, but don't require intubation. It helps with a lot of things. In awake ECMO, you basically can ambulate these patients. And trust me, it's one of the craziest things to see. And I have seen it. It is nuts. You get to turn off sedation, you get to turn off pressor. So you basically get to spare a lot of toxicity early on in the illness. So what I'm talking about is VV ECMO. We're going to bypass the lungs. VA ECMO is used to bypass the heart. And the key is patient selection, and that's what we actually do at our institution. It's going to be young patients, which is a relative term. Single organ failure, which is typically the lungs. However, we do make exceptions for patients who have acute kidney injury because we see a lot of COVID patients that do have some AKI. They have to have excellent pre-illness function. So in other words, they had a high quality of life, very functional before going on to ECMO. And then they had to have a pretty decent oxygen requirement, a PF ratio of less than 100, despite 100% FiO2 and prone positioning. And what we found is that it spared a lot of potential toxicity from the virus and from iatrogenesis of high-dose inotropes and pressors, high PEEPs, high FiO2s for invasive mechanical ventilation, and then sedation and analgesia. And many patients who we did intubate initially, once they got crashed onto ECMO, they actually got extubated rather quickly, 24 to 48 hours. So ECMO in select patients could spare potential toxicity, but think about this early in disease. Don't think about this later in disease because remember, ECMO doesn't really treat anything. It's a bridge to somewhere, and if you wait too late, it'll ultimately end up being a bridge to nowhere. This is the interview I did with one of our intensivists who does specialize in ECMO. I have a lot of little useful pearls there, his thoughts on ECMO and a couple of other things when we were kind of earlier in the pandemic. Finally, I'm going to end with hydroxychloroquine, which has been probably, in my opinion, one of the biggest jokes of COVID-19. So when we look at initial studies, there was all this, it reduced viral load. And so now we should be putting hydroxychloroquine in, the water, and we should just be drinking this. And what we found is in subsequent studies, there was no effect on mortality. And even when you look at the mechanism of how hydroxychloroquine would potentially work, if it was going to work, it would work as prophylaxis. And even in the prophylaxis studies, we saw no benefit. And then ultimately, we started seeing some signal of harm with increased cardiac dysrhythmias from prolonged QT, along with other medications like azithromycin and ondansetron for nausea and vomiting. And so I would say at this point, instead of digging deep into the details, I would say that I think most people are on board at this point. The evidence doesn't support hydroxychloroquine. We've thankfully moved away from this medication. And I'm going to give you 3 QR codes for hydroxychloroquine, looking at treatment, looking at post-exposure prophylaxis, and then ultimately there was 2 big papers published from a particular patient archive, Surgisphere, that got retracted after publication in, I believe it was JAMA and Lancet, and those got retracted. And so I have all those details there, why that actually happened in that 3rd QR code. And there you have it. That's part 2. Again, 5 very controversial topics. I suspect different people will do this differently. If you have any questions for me, just leave them in the question area of this. And I hope you guys found this useful. Again, this was recorded on October 13th. And until next time, thank you for listening and tuning in.